Okay, thank you so much, everyone, for joining our discussion today on the importance of engaging faith actors in improving maternal mental health. So you will see a slide in a moment, yes, with introductions in French to join the language interpretation channels. So please follow those instructions if you need that. My name is Allison Flynn, and I will be moderating the session today. If you are new to Christian Connections for International Health, it is an international network of approximately 115 Christian organizations and 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, and sharing best practices and advocacy. So we will hear briefly from each of our speakers, and then we'll have time for questions. Please use the Q&A box on Zoom to type in your questions, and we will answer as many as we can. This webinar is being recorded, and it will be posted on the CCIH YouTube channel and posted on the CCIH website at ccih.org under events and webinar recordings. So you'll get an email with the link to the recording after it's posted. So my name is Allison Flynn. I'm a senior program advisor for health and nutrition at World Relief. I'm currently based in Malawi, and I provide technical support to World Relief's health and nutrition portfolio at the global level, but with specific emphasis on programs in sub-Saharan Africa. So greetings from Lilongwe. I also serve as a co-chair of the CCIH Health of Women and Children Working Group. So I'm really happy to be with you today. And before our speakers start in, just to share a little bit, mental health, it lacks proper attention in the health sector. Both in funding and response, despite its high prevalence. The Lancet Psychiatry's published Global Burden of Disease study, it was just published last month, showed that mental disorders remain in the top 10 leading causes of the disease burden worldwide. We know that the perinatal period between pregnancy and up to 2 years after birth is a particularly critical time to identify and address mental health concerns, since this period is associated with elevated incidence of mental disorders. Among others, women with common perinatal mental disorders are at increased risk for complications and preterm birth, and their children are at risk for poor long-term health outcomes, many of them related to nutrition. We also know that in low and middle income countries, where many of us work, faith leaders have a strong influence on behavior, and faith-based organizations provide a notable share of healthcare services. So with 84% of the world's population affiliated with a religion, engaging faith communities in addressing mental health issues, including maternal mental health, is a critical opportunity. And so these are the issues that we're going to dive into today. You may be aware that in September 2021, Momentum Country and Global Leadership hosted a technical consultation which engaged nearly 900 participants from 89 countries to understand the issues and evidence around perinatal mental health disorders, share experience in implementing and scaling up maternal mental health programs, and to inform the way forward for maternal mental health to ensure that pregnant and postpartum women receive the respectful and nurturing care that they deserve. So if you missed the consultation, we'll be learning about it today, but recordings are also posted on the technical consultation virtual platform, which is a great resource to dig deeper today after you hear from our presenters. So without further ado, we have much to learn. And so let's first start with Karen Hoehn. So Karen authored the CCIH study of faith actor engagement in maternal mental health. She's a consultant who helps nonprofits, foundations, and multilaterals improve health and reduce poverty around the world. With lifelong roots in faith, mental health, reproductive health, and social justice, she's the director of the consulting firm Bonstar, SRL, and is a founder of the Faith to Action Network. She's based in Brussels, Belgium. So with that, welcome, Karen.
Thank you. Thanks very much. And thanks for this opportunity to present the findings of the study that was conducted last year between May and July, principally. And thank you all very much for participating. I hope you find this interesting. I have a lifelong commitment to these issues and really find them important. So glad that you do too. So next slide. To describe the inputs to the study, we sent out a screening survey to 92 people in the network who we knew to be in some way involved or likely to be involved in the issue of faith and maternal mental health. 31 people responded substantively to that survey. We conducted key informant interviews. There was a fairly extensive search in the literature and in numerous databases, and using a long list of search terms. And so both formal and informal or grade literature were reviewed. And then there was internal expert review from within the Momentum Project. There were quite a few detailed questions we asked in the research, but they can be summarized as you see on the screen. So how do faith-based organizations, FBOs, engage in maternal mental health? And how are they prepared for that? What are the unique contributions of religion and FBOs to maternal mental health? What factors affect FBO approaches to maternal mental health, either positively or adversely? And what's needed to improve FBO approaches to maternal mental health? Next slide. So as was, why do FBOs matter in the provision of maternal mental health services? As Allison already said, most people in the world are religiously affiliated. The world's largest religions all share a belief in the importance of caring for the sick. Religious affiliated institutions provide a substantial share of healthcare services. Religious leaders and religious institutions are seen as credible and trustworthy. They provide extensive community outreach for social support, and spiritual leaders provide a special role in contextualizing the language around care, values for maternal mental health that can help translate important concepts into ways that can be easily understood locally in the local context. The chat is obscuring my view of the slide, but in one of the things you see also is that, of course, faith leaders influence health-seeking behavior. As mentioned, they contextualize concepts and interventions using language and approaches that resonate with the cultures and beliefs of the communities they serve. And importantly, they have a continuous grassroots presence. So this is particularly true in conflict-ridden contexts or hard-to-reach communities where other actors come and go. NGOs, UN agencies, governments appear and disappear, intervening and then going away. Next slide, please. So here's a quote from a United Nations Development Program's report. Faith matters to people and matters to development. In many parts of the world, FBOs and religious leaders are influential in both the political and social spheres and have a broad following in society. Their presence in local communities, coupled with their capacity to deliver critical services, allow them to mobilize grassroots support, earn the trust of vulnerable groups, and influence cultural norms, all of which make them vital stakeholders in development. With their involvement in local communities and their standing as moral leaders, many FBOs and religious leaders command the respect of local and national authorities, which makes them valuable. Slide, please. So the participants and the inputs to the study, when asked what are the top services that FBOs provide specifically for maternal mental health, the general consensus was, or the general overall finding was that not very many that are designed specifically for maternal mental health. So the top three that were mentioned that FBOs provide were inpatient mental health services, So there are a lot of faith-affiliated mental hospitals, or some faith-affiliated mental hospitals, and faith-affiliated hospitals, general hospitals that provide mental health services. We didn't find any that were designed specifically for maternal mental health, but they are designed for addressing mental health issues. Secondly, FBOs and religious communities provide lots of informal peer support through women's support groups, and these provide an important social and emotional network of support for women experiencing maternal mental health problems. And thirdly, they help identify severe mental health conditions during ante and postnatal care, during presentation for delivery, or during follow-up with newborns. Some examples you see in the right-hand column there. These include, informal emotional support during maternity and delivery, being present and praying with the woman, providing some education and awareness raising integrated into a community health and education work that many religious communities provide. Psychosocial counseling to pregnant and postpartum mothers through focus projects and specialty units in mission hospitals. I should mention that oftentimes maternal mental health specific interventions are project funded. They're time limited and for specific discrete outputs and outcomes over a short period of time. And then FBOs have also been known to, in their disaster response, train various important stakeholders, Ministry of Health staff and so on, and faith leaders on identifying trauma and providing psychological first aid. Next. As you can imagine, faith-based organizations and their approaches can either accelerate or hinder progress on maternal mental health. On the positive side, FBOs and religious communities that support mental health and understand mental health can provide incredibly powerful incentives for people to seek care, for women to seek care. Also, many religious communities provide a wide range of support for women who struggle with mental health problems. And last but by no means least, faith-based care tends to take, as was described by the participants to the study, a holistic, more than medical approach to wellness and a whole person response, which includes spiritual, emotional, and mental aspects. On the hindering side, on the harmful side, there are a wide range of harmful traditional practice, and these sometimes either masquerade as being faith-related, or they are actively perpetuated by religious leaders and faith communities around the world. And also, of course, stigma against mental health is highly pervasive around the world, in all the world. But especially, or also, of course, in religious communities. Religious communities are not immune from the stigma that exists widespread throughout the world towards mental health. Next slide. So here's a quote from a key informant. Many women, for example, with psychosis, get a wide range of support from churches and mosques, ranging from fairly helpful, formal or informal, to inappropriate, judgmental, and sometimes quite abusive, for example, all-night prayer vigils that blame the woman for her condition. Next slide. What are the unique contributions of religion and FBOs to addressing maternal mental health? As I mentioned, FBOs see people holistically. There's they bring an awareness of spirituality and its connection with mental and emotional well-being. A supportive faith community can be highly protective, reducing the likelihood of having a mental health disorder, and making identification and referral more likely. Also providing a more supportive community that makes recovery easier. FBOs have strong community trust. Religious leaders are respected, trusted, and in demand. As I mentioned, faith leaders can help translate mental health concepts into the local context and culture for ready absorption and understanding, and can help demystify harmful attitudes and practices. And I've mentioned women's faith groups, which can help transmit anti-stigma, pro-mental health messages. FBO missions and purposes often align with maternal mental health. Spiritual health and values enable care for women's whole being. Most religions believe that people should be kind, help others, and be generous, and faith adherents are very typically called to love and care for others and to offer hope. And most religious leaders, or many religious leaders around the world, provide counseling of some sort. And then the last bit I'll mention is that FBOs are present where others are not. We've talked about that. Religious leaders are involved with women from womb to tomb, from birth to earth, throughout the life cycle. And the FBOs are continuously present in communities where others come and go. Next slide. Here's another key informant quote that was particularly insightful. Faith organizations are often the center of community support system. It's where people turn when they need help, for fellowship, for financial support, and where people find informal networks of support. They're incredibly important in providing that baseline emotional support for women who are having problems. It's where people go first when they need support. They go to church or mosque because that's the cultural understanding of this being a spiritual issue. In the best cases, they can facilitate that by being thoughtful and caring in response to people's needs. Next slide. So this triangle represents the challenges to advancing maternal mental health with FBOs. The bottom tier of the pyramid, the largest one, are the broad range of socioeconomic and cultural factors that contribute to maternal mental health: poverty, stigma, women overburdened with caring for income generation, family, household work, male dominance and lack of female autonomy, for example, to seek healthcare supports when needed, harmful family power dynamics, and a view of mental health as a Western construct. Again, reminder, these are the inputs from participants to the study in the literature. The middle tier is harmful beliefs and practices. I've addressed those issues already to some extent. And then the top tier is lack of training, because even though many religious leaders provide counseling, for example, very few are trained in maternal mental health specifically. Next slide. A key informant quote: mental health issues are culturally embedded issues. The diagnostic and statistic manual and other rich world clinical approaches do not mostly meet people where they are in low and middle income countries. So you see lots of women being put on the wrong medications. This does not help, and it is poor quality care. FBOs are well placed to contextualize care rather than copy and paste diagnostic protocols. If asked, the women themselves would say that they want more supportive communities, pastors, family members, that the social factors would be more open and helpful with less stigma. Slide. So how can we support faith-based maternal mental health with stronger systems? The top priority most commonly cited across the board by participants to the study and by the literature was that there should be an increase in training to help FBOs identify, diagnose, and intervene sensitively at all levels of the health system, including in the community, with community health workers and traditional birth attendants. Excuse me. Also cited as important were anti-stigma awareness raising among FBO clinicians and religious leaders. It's interesting that several people mentioned that even clinicians for faith-based organizations hold their own stigma against mental health, and so anti-stigma awareness raising can be helpful there. Increased mental health services availability and resources is another important way to strengthen FBO interventions on MMH. Creating partnerships and linkages that improve service system collaboration, including across development sectors, since poverty is a root cause. Increasing systemic resources for faith-based outreach in communities. Current efforts typically are not integrated into sustainable system change. And then there were quite a few other ways we could support that were mentioned, maybe not as commonly across the board among all participants, but that came up. Improving service system collaboration, ensuring that healthcare service providers can screen for maternal mental health, making sure that mental health is integrated into maternal health, making sure that drugs are available, and improving clinician sensitivity and cultural appropriateness. Next slide, please. So another key informant quote: at the community level, having culturally appropriate care would help. It's hard to translate Western mental health care into different cultures. Sitting one-on-one in an office with a counselor would not be welcome or helpful or even possible in a lot of contexts. Digging in deeper into the cultural appropriateness of taking care of women's mental health needs is needed. And I remember one example in particular of a woman saying that oftentimes women are accompanied by an auntie or a mother-in-law who is uncomfortable with the woman herself saying that she has a mental health needs when they're in a clinical setting. And so the woman is constrained by her family social dynamics from being able to say, help, 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 help. All right, next slide. This study was a very, very, very small study on a very, very large issue. So a lot more research is needed on faith and mental health. Bullet, please. The research on the healing effects of prayer, for example, there is a bit of that, but it's riddled with assumptions and contradictions that make the subject a scientific and religious minefield. That requires more thought leadership to figure out how to get good evidence to assess the healing effects of prayer, positively, negatively, otherwise. Bullet. There's very little systematic evidence on how religious communities as a whole deal with maternal mental health. Anecdotal evidence shows both supportive and harmful effects, but almost nothing that's empirically rigorous. Next bullet. I should also mention that even those who participate in studies like ours have come to the study with vastly differential knowledge, backgrounds, and cultural and linguistic filters that affect how they informed the study about mental conditions, their assumptions about gender dynamics, social power, and religion. And that means that the key informant responses do not always naturally fit into neat little boxes. Is there another bullet there? No. Okay, so I think this is the last key informant quote. It is not possible to deal with the aspect of mental health that comes from stigma and discrimination without working with faith, because faith communities are a source of a lot of that stigma and discrimination. And on that note, I thank you again. I'm done, and I'll be happy when the time comes to answer any questions that I can. Thanks very much.
Thank you so much, Karen, for your presentation, for this overview of this really valuable landscape analysis. So we're going to move on to our next presentation from Suzanne Stalls. You can remember to post any questions that you have in the Q&A box on Zoom, and so that we can discuss those after the conclusion of Suzanne's presentation. So Suzanne Stalls is currently director of the Maternal Newborn Health Team for Momentum Country and Global Leadership, which is a global technical leadership award funded by USAID in a consortium directed by JPIGO. In her role, she contributes to global technical leadership and learning and supports the policy dialogue required for achievement of global MNCH, family planning, and reproductive health goals through these initiatives, strategies, frameworks, guidelines, and action plans that have been endorsed worldwide. Suzanne has worked throughout the world during the past 25 years in the fields of maternal, newborn, and reproductive health. Her background spans from clinical practice and midwifery to providing technical support to global health programs, to improve essential interventions in maternal and newborn health through careful attention to quality improvement and learning approaches which embody best practices and collaboration with national professional associations to strengthen management and provide leadership for their profession. Her particular focus is in antenatal care, quality improvement linked with clinical capacity building, and respectful maternity care. So Suzanne, we're really grateful to have you with us, and we will hand it over to you for your presentation.
Thanks so very much, Allison, and welcome. Good morning, good afternoon, good evening to everyone. And thanks so much for joining us for this, what we believe to be a very critical topic. And we are so pleased that we're able to collaborate with stakeholders around the world to bring more prominence to this topic and to begin to examine ways in which we can respond to women and families to support them as they make their journey through mental health. So next slide, please. So we were fortunate in that as Momentum Country and Global Leadership began its programming, that our colleagues at USAID came to us and said, you know, we feel like this is an area in which women's health has not been featured prominently, and we would like to create more interest and create a spotlight around this. So we embarked on a global landscape analysis, as you can see, in 2021. And as we were underway with this large landscape analysis, we collaborated with CCIH, and as you heard from Karen, she was able to really draw in faith-based organizations. At the same time that we were assembling this landscape analysis, we decided that one of the outputs of the landscape analysis should be a maternal mental health global technical consultation. So again, in collaboration with our partners within the consortium and with USAID, we began to put that together. What we did was initially identify a technical advisory group of stakeholders throughout the world who had been very involved in maternal mental health. And with their guidance and support, we put together the Global Technical Consultation, which is online through the Momentum website, and you are able to access that. It was an extensive 3-day technical consultation. There are many panels that you can access, and there are a number of panels with faith-based organizations. So now where do we go from here? What we will be doing, next slide please, in the next year is really focused dissemination activities. So we'll be looking at how we can disseminate the findings from the landscape analysis and from the global technical consultation through FB-MMH, which is a knowledge hub, a knowledge platform that has come on the global maternal and newborn health scene in the last 2 years, and the source of a great deal, a way to access a tremendous number of resources. There'll be blogs, or we have put together blogs and webinars, one of which is this one, publications and manuscripts. And then most importantly, in addition to highlighting and disseminating the realities of this field, we will be collaborating with global stakeholders again to put together a theory of change, which will then help us to give direction to a country-driven maternal mental health community of practice. And then we'll continue through this community of practice with this theory of change to strategically collaborate with our partners to advance maternal mental health globally. And then also begin to look very closely at how implementation research might be a useful contribution to this field. So next slide, please. So with the co-creation of the theory of change in the community of practice, we'll be drawing again heavily on the expertise and the knowledge of our technical advisory committee. We'll be putting together a country-driven, country-led steering committee, and that committee will lead and inform the development of the theory of change. And then with a human-centered design firm that is a partner in MCGL based in India, we'll lead the steering committee members and other key stakeholders in a co-creation process so that we can validate and finalize this theory of change. And again, we see this theory of change as the basis for driving subsequent action. And then we'll begin to look at the elements of putting, how do we form a community of practice that will serve best those that are interested around the world in advancing this topic. Next slide, please. So what do we know so far, given our landscape analysis, given the technical consultation? Where are the gaps in knowledge? And what we understand now is that our evidence should expand in order to really include findings from all sorts of different contexts, including vulnerable populations, such as women in conflict settings, adolescent girls, any number of contexts. And so that is one focus that we feel like we can provide contributions towards. The other is to expand the evidence base beyond postnatal depression. There's been a significant number of work, or a significant amount of work done on postnatal depression, but we feel like we need to look a little bit deeper into different common perinatal mental disorders as they're referred. Center research on and practice on the expressed desires of women and girls. One of the things that we noted is that, and Karen referenced this as well in her talk, that really there, for women in relation to mental health, it really represents a nexus of multiple factors. There are socioeconomic factors, there are educational factors, there are gender-based factors, and we really feel like it's important for women's voices to be able to speak strongly to what they need. And then the identification of integrated approaches that improve both women and children's health. We know from the research and the literature that women's mental health impacts significantly the well-being of children and families. And so how do we integrate those approaches? And one of the things that we'll need to examine very closely is what are the tools and the mechanisms, and how do we measure common perinatal mental disorders, given that we are looking at this in a number of different contexts. And most of the studies have been utilizing tools developed in the Western context, which oftentimes are not necessarily applicable to the context that many of us work in. So next slide, please. So how do we begin integrating and expanding maternal mental health services? So obviously there are a number of different levels that we can begin to examine to understand where we might support women and families with this issue. So at the community level, there are obviously community health workers, peers, grandmothers. This is meeting women where they are located, which also helps them to access care if they're not seeking care within health facilities. The children and family approaches, many of the key informants in the landscape analysis began to describe to us approaches that they had used by focusing on children, and thereby removing some of the stigma and the guilt that is often associated with women reaching out for mental health support. Then again, clearly facility level antenatal care and postnatal care, having healthcare workers trained in both recognizing, diagnosing, treating, and or referring is going to be a key component in strengthening health systems. And that leads directly into how do we provide support to providers in pre-service and in-service education. And also, very importantly, what we know is that healthcare workers are often women themselves. They are subject to the same pressures that women in the community. We also know that the pandemic has exacerbated mental health crises within healthcare workers as much as it has in the community as well. And then lastly and importantly, the traditional healers and faith-based organizations, as Karen eloquently described, play a very key part in creating a link between mental health and spirituality and faith workers. So next slide. Okay, it's always hard to get through a very complex conversation in a short period of time, but these slides describe basically what can be done at national policy level, the health systems level. How do we focus on person-centered, rights-based care? How do we integrate within the health system? How do we create better policies? Next slide, please. How do we address the mental health needs of healthcare workers? And how do we support healthcare workers to break down stigma and discrimination from the facility level to help provide respectful and empathetic care? And then how do we incorporate this into pre-service and in-service training? Next slide, please. Community level strengthening, and how do we engage community health workers so that we are relying on the valuable input and the trust that they engender with that within their communities without relying so heavily on them that we overburden them as well. Next slide. And with that, we draw to a close, and thanks so much for your participation, and we welcome your questions. Thanks so much.
Thank you so much, Suzanne, for what you've shared. We are, and thanks to Karen, thanks to all your presenters for your excellent presentations. So we're now going to open up to questions. So please, if you haven't already, put your questions in the Zoom Q&A box, and we will go there. So we have a couple questions already to start off. And so I think this first one I'm going to direct to Suzanne. Just as a reminder to everyone, the recording of this presentation will be sent to everyone who registered for the webinar, and you'll be able to find it on the CCIH YouTube page, I believe, as well afterwards. So if you want to look back at something in the slides that you may have missed or you want to see again, that will be available to you. So Suzanne, we have a question. So from Benetta Fall. She's the founder and president of the LATE initiative. And she says she'd like to include mental health in their programs. What are the possibilities for a partnership?
Thanks very much for that question. I think, one of the ways that we really are hoping and anticipate that the community of practice, one of the functions, I should say, that we are hoping that this community of practice can serve is to enable connections to be made and for people to reach out to partners and other organizations throughout the world that are busy implementing these programs on the ground. So we would really see this community of practice as a vital mechanism for connecting others. And that would be my best suggestion. And we anticipate that we are now February of 2022, and we are hoping that by laying our groundwork for drawing in global stakeholders, that we will soon be able to put together this community of practice by the fall. So that stay tuned, and as soon as we have this community of practice ready, and we will be sending out notifications so that people can begin to participate. Thanks so much.
Yeah, thank you so much, Suzanne. It's so exciting to hear about the progress and the community of practice to come. Yeah, really exciting to hear about all these components. So Karen, we have a question for you. It's how do you think that building a glossary of common terms could contribute to multilateral funding applications for organizations working with local churches where Christians are minorities.
It sounds like a great idea. It always, yeah, I think it's a wonderful idea. And maybe, I don't know if that's something that the Momentum Project could take on or something that CCIH could take on, but you know, I think it's a fantastic idea. Yeah.
I would love to just to note that in the chat, there's a lot of great conversation happening back and forth there, and folks sharing about their experiences and some different tools and materials. And so I would, yeah, just recommend if you want to take a look through there and learn more about what some folks are sharing.
Oh, sorry, Allison, I'd like to respond to the woman who is in Cameroon. I don't dare pronounce her name. I'm afraid I'll butcher it. But I think the question that he or she, and again, apologies for not understanding well the names, but I think the question that's been posed is a very important question. And I know that Karen touched on this some in her talk, but the question is the role of community-based organizations in impacting mental health, and that her observation or his observation had been that faith leaders sometimes have a tendency to use mental illness and faith to show that there's consequence for sins and that demons exist. And I think that the point that you raise is very important in that it points to, as we begin to think about how to work with communities, that it will be really important to draw in faith leaders as part of the stakeholders and to look at finding common ground and understanding how the kind of language and the way that we communicate what mental health is about and what this means for women and families. So I don't have an answer to your question. I do, however, appreciate that input because I think that this is something that we'll need to continue to ponder and work on. So thanks very much.
I may just add on that in answer to the specific question at the end there, are there universal efforts being put in place? None, no, that there are not universal efforts being put in place. But it's a great idea to ensure that faith leaders can be oriented during their training.
Yeah, for sure. I think maybe I can tag on to that with another question we have from Angela Gorman. She talks about her NGO provides misoprostol to treat or prevent postpartum hemorrhage to part or whole of 5 countries. They're not faith-based, but have seen and witnessed, experiences where people accept the unacceptable with maternal and child morbidity and mortality as being God's will. So this question, I think this kind of tags on, Suzanne, if you wanted to talk about this a bit of how do you deal with this? Are you including any non-faith-based organizations in the research that you are doing?
Okay, let me just make, are we including any, I'm sorry, say that again?
Sorry, it's kind of a 2-part question. In my notes, I have them pulled together. So yeah, there's just one part would be how about this question of when people say, this is God's will. But then also in the research that you're doing, are you including non-faith-based organizations? So maybe Karen, you might want to talk about that first one as well. But in Momentum's work, are you including non-faith-based organizations in your research?
Well, let me answer the second question first because it's an easy one to answer, and that is yes. In the landscape analysis, we reached out to faith-based organizations. Through CCIH, we reached out to people from multilateral agencies at a global level. We reached out to country, national level stakeholders, and then communities. We cast a very wide net. So yes, we did try to include a broad range of voices. In terms of your question about God's will, I've done this work for quite a while now. I practiced clinically as a nurse midwife for many years as well. I've encountered that response many times. It's a difficult question to answer because in many respects, these communities, I think this, it doesn't hold true as much today as it did even 10 years ago. But these communities are deeply religious. Oftentimes, they have not been able to access care frequently or quality care oftentimes. And I think in their search for making sense of what is an unexplainable and an unjust and an inequitable event, this is how they are able to respond to deep sadness. And I have also been in situations where, people have said, oh, it's commonly accepted, women and children die all the time. And I strongly reject that statement because I have never known a family or a midwife or a nurse or a doctor who isn't deeply affected by any of those events. So I think part of it is just, part of it is improving access to quality healthcare. I think part of it is community awareness and education. I think part of it is addressing gender bias. I don't want to pretend that we're anywhere close to the end. I do think that we're making progress, as evidenced, just by, the decrease in maternal and neonatal mortality worldwide. We're not where we want to be, but we are moving towards those goals. So a good question, and it's a hard question. So I'll stop there, Karen, please.
Karen, did you want to add anything on? You can.
No, not necessarily, although I did just see a question pop up in the chat. I don't want to take things out of order though. Should I wait?
No, it's all right.
Yeah, I think there's a queue with questions in order, so I'll wait.
Oh, okay. So great. Well, so each country has its own faith system, and we know, and this person says the same is true for Southeast Asia. With various religions and faiths, women face innumerable obstacles to keep themselves and their children safe and healthy. So are there any plans to map such systems and to understand them? And maybe can faith-based work done during polio eradication provide any clue in this work? This could go to either one of you.
It may be that my internet is unstable, but I'm not aware of maps, and it would be great to share lessons. If there are lessons to be shared from the engagement of faith-based groups in polio eradication, that would be great to share. If there's going to be a community of practice, I see there seems to be quite momentum in the chat for a community of practice to be created on this, which I would heartily endorse. That would be a good place to share that information for sure. Yeah. And even perhaps to begin some additional networking to do a more thorough mapping. I mean, the world is a big place. You can't map everybody everywhere doing everything, but some mapping of key initiatives would be very helpful. Yeah.
So, Allison, I see a couple of questions in the Q&A box about, first about schools and then also about community health workers. So could we respond to those?
Yep, that was where we were going to head next.
Oh, okay, sorry.
Yep. So
I'm flipping back and forth between the chat box and the Q&A box. So
yeah,
sorry if I'm jumping out of order.
no, not at all. Yeah, just as a reminder to everyone, if you have questions, please put those in the Q&A box and we'll get to those. So, Suzanne, this question, ideas on how to avoid over-reliance on health workers at the community level. You talked about this a bit in your presentation, which is so critical. So ideas that you might have to share?
You know, this conversation about the over-reliance on community health workers has been going on for a number of years now. And as you said, it's a critical conversation. I think in the course of the landscape analysis and in the course of the discussions that took place during the global technical consultation, I think at the end of the day, most people felt that community health workers, I mean, I'm stating the obvious, are a vital part of the healthcare system. We have relied on them, you know, to a larger and larger extent as time has gone by. Their tasks have become more and more complex. And at the end of the day, probably the best answer is to understand that this truly is a part of the health cadres that exist within the health system, and as such need to be recognized and then compensated accordingly. Now, I completely recognize that this is a challenge and that we're oftentimes in health systems that have severe resource constraints. So I think that in many ways, what is best to keep in mind is that many of these goals are goals to which we have to work towards, and we don't have perfect answers at the moment. But I do feel like, having witnessed firsthand over and over again the critical role that they play at a community level, I feel like this is something that we need to focus our attention on.
Yeah, thank you so much. It's such a complicated issue, and I think even Phil Moses was sharing a bit in the comments about some experiences that Food for the Hungry has had, and I know World Vision has also done. They've done work together on this issue even of maternal mental health. I think Mona shared in the chat box a link to a webinar that we did on that a year ago. If you want to learn more, but looking at how even at the community level, how do we, what different structures can be used, understanding, community health workers are a critical part of the cadre, and but then also who else can be involved, and so that might be a resource folks to look at. So continuing, so Phil also mentioned that that Food for the Hungry has established a small community of practice regarding maternal and mental health in sub-Saharan Africa, with all the work they've done. So he asks, how can their community of practice link up with or support the community of practice that you are establishing?
I think we need your email. I think that's probably our best bet. And I love hearing that you've established a community of practice in the area where you work. So I think let me check with Mona and make sure that we're able to connect with you. Thanks for your interest.
And just a follow-up question. So how will the theory of change in the community of practice avoid implicit Western bias against the supernatural in explanations and interventions?
I think, go ahead.
Go ahead, Suzanne. It's okay. Go ahead. I'll join in after if you like.
I think primarily by drawing in, all different aspects of stakeholders, so that it is not driven by Western stakeholders. That is truly our commitment. So and also those of us who come from the Western context, obviously it is our responsibility to continue to examine closely whether or not we're bringing that context too strongly within the conversation. And I can assure you that we will do our very best to avoid that. Thank you. It's a very important question.
The only other thing I would add there is I also did a study last year on how faith and secular actors can collaborate effectively to advance sexual and reproductive health and rights, which is related to maternal mental health, but and the organization that the study was done for, RFSU, was particularly interested in how there can be collaboration on LGBTQI issues, on abortion, and on comprehensive sexuality education, 3 very difficult issues for a lot of faith actors. And one of the important findings is both sides, right, faith actors and secular actors, operate in very different worlds using very different language. So it's most important for both sides to increase their cultural literacy, if you will, for the language and concepts for their partners. And it requires remaining open-minded, non-judgmental, building long-term trusting relationships, and expecting that there will be some challenges on the way. I'd be happy to share that resource later if it's helpful, but it is very, very challenging. There's no question about it. And there's work that's required on both sides.
Great, thank you both so much. We just have a couple minutes remaining. So I wonder if Karen and Suzanne, if you have maybe a 1-sentence closing statement that you might like to share with us. I know synthesis into 1 sentence can be tricky. But yeah, any last words that you have for us before we close?
Shall I go, Suzanne, while you're reflecting? So I would just say that, the promise and perils of FBO engagement in maternal mental health are tremendous. There's tremendous promise, and there's a lot of peril already in existence in the world. So there really needs to be more research on the topic of the intersection between faith and maternal mental health, and multidimensional research. It really needs greater investment and ongoing attention and work prioritization by decision makers. So I would leave with a plea for more attention to this crucial issue.
I think I would just say very simply that there is no health without mental health. And because of that, I am hoping that all of us can begin to understand that when we think about the health and well-being of mothers, of women, of children, that we need to incorporate those dimensions that Karen referenced, that this is multidimensional, and it's not enough to just survive. We have to also focus on thriving. So thanks very much for your interest.
Yeah, thank you both so much for your presentations, for your thoughts, for your engagement, and to everyone for joining us. We hope you enjoyed this session. CCIH would love to hear your thoughts on the webinar, and they will be following up to get your opinions on how it went. So in the chat box, you should see a link to tell us one thing that you have to say about the webinar. So it's just a quick way for you to respond that shouldn't take you too much time. So let's close in prayer as we finish. Gracious God, we are so grateful for the opportunity to gather and learn today. Would you use this research to inspire further work, empower faith-based organizations and faith communities to see how they may be involved, and to help us to make a tangible impact in the realm of maternal mental health. And above all, Father, we pray for those women around the world who are suffering even today. Would you meet them in their time of pain, provide the support that they and their families need, and would you use their neighbors, communities, perhaps even ripple effects from today's presentation to bring hope and healing. Go with us as we go about the rest of our day today. and all that we have ahead of us. We give you the honor and pray these things all in your name, Jesus. Amen. Great. Well, thank you everyone so much for joining us, and to our great presenters. Hope you have a great rest of your day.
Thank you.
So much.